Oh, yeah. Okay. Right. I'm the first male. Okay. I'm going to give you a brief update on the artificial pancreas and where we are going, hopefully, in the next 5 to 10 years. So these are my disclosures. I have no conflicts. I'm funded by NIH and Minimed, previously known as Medtronic. So the learning objectives, I want to review a few, not all, landmark clinical trials of AID, which are automated insulin delivery devices. Recent advances in AID approaches and future directions and challenges. So let's go back, and this is some of the pictures that have been used by one of my previous speakers. We have come a long way from even 30 or 40 years ago from the first artificial pancreas, which was the biostator, then the Kadish pump, and now eventually to the 4 approved, FDA-approved systems that are currently in the US, the Tandem, the Medtronics, the Omnipod, and the iLet. So the first landmark study, or one of the first that was published in New England Journal about 7 years ago, was a 6-month randomized multi-center trial of closed-loop control in type 1 diabetes. It enrolled 170 patients with type 1 diabetes, randomized 168, and it was perhaps the first large multi-center trial that I know of in this population that every one of the enrolled patients completed the study. So full 100% of them completed. And basically it showed that the closed loop group, which is in pink, versus the control group, which is in blue, showed that they had greater percent time in target, a better hemoglobin A1C, a greater percent time with glucose between 70 to 180, especially overnight. And that is a feature you will see in all of these closed loop trials. And I tell my patients that patients with type 1 and type 2 diabetes, if patients with diabetes stop eating, glucose control won't be a problem at all. But that is not reality. And continuing on the primary outcome, there was an increase in time in range of about 11%, which was statistically significant. And there was also a decrease in time below range, that is reduction in hypoglycemia, both in time below 70 and time below 50. So to summarize, 100% of the participants completed the randomized control trials and were actively using the system at the end of 6 months. The closed-loop system was superior to the sensor-augmented pump in all glycemic control parameters, and the results were consistent across a wide range of A1C and ages. Subsequently, there was a study of closed-loop systems in pediatric population between the ages of 6 and 13, and suffice it to say, the results were similar. That means closed-loop systems was better overall in diabetes control in these kids with type 1 diabetes, both overnight, achieving a time in range of almost 100%, and there was significant improvement in time in target and other parameters, outcome variables. Currently, closed-loop systems are approved in the US in children above the ages of 1. So above the ages of 1, they are approved for use in the US. What about adjunctive therapies? There have been a lot of adjunctive therapies that have been used in patients with type 1 diabetes. And one of the first ones we did was many years back when we used the SGLT2 inhibitors, empagliflozin, in combination with closed-loop therapy in adult patients with type 1 diabetes. SGLT2 inhibitors, as you know, are still not approved for patients with type 1 diabetes because of the risk of ketoacidosis or euglycemic ketosis. But we used a very low-dose empagliflozin or Jardiance at 5 milligram daily versus no empagliflozin in closed-loop systems. And we found that the primary outcome, the time in range in blue, was higher with 5 milligram of empagliflozin versus no empagliflozin during closed loop. But a point of caution was that one of the patients on empagliflozin developed ketoacidosis. So again, there is a real risk of ketoacidosis in these patients with type 1 diabetes, because empagliflozin raises glucagon levels, and glucagon, as you know, is the most potent ketogenic hormone known to humans. So it is very important that we be careful if you consider use of empagliflozin in patients with type 1. So to summarize this study, 5 milligram of empagliflozin adjunctive therapy with automated insulin delivery improves glucose control 24/7 in type 1 diabetic patients. Empagliflozin increased time in range by 10% by lowering hyperglycemia. It also appears to lower glucose variability, but ketosis remains a challenge. So it needs further evaluation, and there are trials that are currently ongoing that are using still lower dose of empagliflozin, 2.5 milligrams daily, with a modified algorithm and use of continuous ketone monitor, as has been brought forward by Abbott. Next, we look at a few studies on multi-hormone closed loops. That is not only insulin, but insulin along with other hormones. So this was one of the first studies published about 5 years ago, where they used a fully closed loop glucose control with a bihormonal artificial pancreas in patients with type 1 diabetes. And this used insulin and glucagon, because as you know, insulin is not the only hormone that regulates blood glucose in humans. There are other hormones as well. But this was a small study by Dr. Hans de Vries in Europe. It was 2-week periods in each arm and a small study in 23 participants. But you will realize that this is a lot of machinery on an individual patient, because not only is there an insulin pump, there's also a glucagon pump. There's a lot of, there are 2 sensors, two infusion ports. There's a lot of hardware attached to the patient, and that increases the burden on the patients to carrying all these various machines and pumps on their system. Subsequently, there's been a lot of other studies, including insulin and pramlintide, because as we all know, insulin is not the only product from the beta cells. Pramlintide or amylin is also secreted, co-secreted with insulin. And amylin, what amylin does is that it reduces glucagon and slows down gastric emptying. So there have been multiple studies that have co-infused insulin and pramlintide, which is an amylin analog in patients with type 1 diabetes. But it doesn't work in every patient, and the risk of nausea and vomiting is significant because pramlintide slows down the gastric emptying. What about recent literature? This was one of the earlier studies done about 2 to 3 years ago, where they used closed loop system in pregnant patients with type 1 diabetes. Now, use of closed loop system in pregnant type 1 diabetes is still not approved by the FDA in the US, but we use it all the time off label, and it really works. There's no question about it. Better than using a sensor augmented pump or using the basal bolus regimen. So although it's off label use, I use it all the time. And all of these systems, whether it's Medtronic or the Omnipod or the Tandem, works pretty well in pregnant patients with type 1 diabetes. Next is something called the neural net artificial pancreas. So basically, it is use of a different AI-based algorithm in the closed loop system. And this was a study published a few years ago by my ex-colleagues at the University of Virginia, which showed that the neural net, which is AI-based closed loop system, works just as well as the traditional closed loop systems, if not better. But the benefit of the neural net artificial pancreas is the computational demands on the pump is 6-fold lower than the standard conventional algorithms that are, with the result that the batteries in the pumps last longer. And it can also input other inputs into the closed loop systems, including use of GPS. For example, if the GPS tells you that the patient is going to KFC to have a meal, it can dial up the insulin dose. Versus if the GPS tells you that you're going to the local gym to exercise, it can dial down the insulin. So all these variable inputs can be presented into the closed loop system so that it truly becomes personalized to that patient. So there has been also studies in the use of these closed loop systems in type 2 diabetes. So not only in type 1 diabetes, in type 2 diabetes is of significant benefit, especially in those who have reduced beta cell reserves and is using basal bolus. It works just as well, if not better. There also have been studies recently that was published last year in Diabetes Care, where it showed that in patients with type 2 diabetes, it doesn't matter what the C-peptide levels are. Works just as well. Whether or not the patient has reasonable, adequate, reasonable endogenous insulin reserves, it works just as well. So what we are trying to do is through these trials, we are trying to persuade the US FDA to approve these closed loop systems for patients with insulin-taking patients with type 2 diabetes. How about automated insulin delivery in older adults with type 1 diabetes, over the ages of 60 and 70? Works just as well. Use of other adjunctive therapies like semaglutide, which I believe is now available in this country. That is, use of semaglutide as an adjunctive therapy with automated insulin delivery in type 1 diabetes works quite well. So again, all of these are an effort to persuade and show the FDA in the US that that closed loop systems can be used in patients not only with type 1 diabetes with other adjunctive therapies, but also in patients with type 2. And pretty soon, it'll probably be the standard of care in all insulin-taking patients with diabetes, and hopefully around the world. What about what's happening in the pipeline? We are involved in a study that is looking at the effects of artificial pancreas on physiological changes to carbohydrate metabolism during and after puberty, because puberty is when a lot of changes occur in metabolism, and whether artificial pancreas technology can learn from that and adapt to each individual child or adolescent with type 1 diabetes. We are studying artificial pancreas in pre and post solid organ transplant patients with type 1 diabetes. Closed loop systems in those with diabetes with significant hypoglycemia unawareness or autonomic neuropathy. Use of closed loop systems with continuous ketone or lactate sensors so that they can exercise better. Multi-hormone closed loop studies and adjunctive therapies of closed loop, as I've showed you some examples of amylin analogs, SGLT2 inhibitors, and GLP-1 agonists. What are the future prospects and challenges? Fully automated closed loop system that works well without any patient input is still a significant challenge. Don't let anybody tell you otherwise. There have been a lot of studies that are coming out, oh, it's fully automated. With respect, it's not really fully automated. So the Achilles heel for closed loop system to becoming fully automated is still exercise. Cannot handle exercise, especially the single hormone system. So again, it remains a formidable barrier in all closed loop systems for both type 1 and type 2. There's a study that is currently going on in the EU called Forget Diabetes. So it is a bionic invisible pancreas, and where an immuno-optimized, fully implantable, fully automated closed loop, as they say, with intraperitoneal glucose sensing and insulin delivery. So it has developed a novel ecosystem of nanotechnology, control engineering with personalized adaptive algorithms, biomaterials, and surgery. So insulin refills occurs weekly via an oral recyclable insulin pill that attaches to the pump that is present in that is attached to the walls of the stomach. So the pill with insulin it's almost like science fiction, believe it or not. One of my ex-colleagues is a co-investigator in that, and he tells me that is going very well, but I'll believe it when I see it. But an important aspect of it is accessibility of AP systems across all sections of society and across the world, including India. I know for a fact that both Rita and I have been collaborating with a group in Indian Institute of Science in Bangalore, Dr. Padhi, who's a rocket scientist. He designed some of the rocket technology for the Chandrayaan that went to the South Pole of the moon. And he is, with funding from various institutions in the US, in India, is building a closed-loop system with an indigenous insulin pump and sensors. So I don't know whether he's in the meeting or not, but he's building it for all patients with type 1 diabetes. So again, that's coming up. Thank you very much.